Welcome to DocPod. Hear health.
Well, I'm here with Dr. Chris D'Angelo, who is a board-certified internist, board-certified in critical care medicine as well as pulmonary disease. Cleveland Clinic trained and is now practicing in Ohio. And one of my close buddies for the better part of 2 decades. So welcome to the show, Chris.
Thanks, buddy. It's good to see you.
Hey, man. You too. We're going to talk about a lot of things, mostly that cough, but
perfect timing.
Exactly right. And make sure I'm saying this correctly: eosinophilia, asthma, different treatments, different things that you're seeing in your practice, in your patient population, things that people present to you, how you treat short, long term, etc. So. I guess maybe firstly, give me a quick little synopsis, little bio. How'd you get to where you're at?
It's a good question. So obviously we were together in college, so I didn't really start studying medicine until my senior year of college. My roommate is also a practicing physician. I think we both know him, a Dr. Thomas Charles Pitts, board certified neurologist practicing in New York right now. One of the smartest guys we ever probably met in our lives. And he was studying to be a doctor. I thought it was super interesting. And he's like, hey, man, just take this class or whatever. So I took the class, and it was the first A I ever got at Florida State. Ever. So
which class?
Brain and behavior. Do you remember that?
Oh, I love that class. I got an A in that too. Should I have been a doctor?
Yeah, I mean, it literally it paved my way to do what I'm doing now. I swear.
That's awesome.
I promise you. Yeah.
I got
100% in that class. Yeah. I didn't get a single question wrong on any test.
I think we took that class together.
We did? It was early in the morning.
Yeah.
Like super early.
Yes, the earliest ever. I missed a lot of them because of that.
Yes, or we did it because it was early.
Right.
Also.
Oh, man, memory lane. That's great.
Yeah. So, that was my first, kind of introduction into, studying medicine. And then I moved back home, and I went to school at nighttime at FAU in Boca, obviously where you were from. And then got into med school, and that was pretty much it, man. I stayed at Cleveland Clinic in Weston, Florida I was there for 8 years. Yep. I did the last 2 years of my medical school there, and then I did 6 years of training there, 6 years of residency, internal medicine, or 3 years of residency in internal medicine, and then another 3 years doing pulmonary and critical care fellowship.
Awesome. And
that was it, yeah, and that's where I'm at.
And then you practiced down in Fort Myers for a little bit, correct? And then moved into Ohio semi-recently?
So my first year out of training from fellowship, I practiced in Fort Myers for a year. But it was with a big group of a lot of pulmonologists, you know what I mean? And everyone kind of you were under someone's thumb all the time. You couldn't really do your own thing because the group had a mindset already, right? You had to kind of just I don't know what's the word I'm looking for.
It's kind of a cog in the wheel, right? It's not necessarily a bad thing, but you're coming into an established practice. So,
I mean, don't get me wrong. I appreciate it because I had a lot of patients, that were already there. But it was a lot more clinic time too. And I'm more of the ICU guy. I pulmonary clinic. I do love it obviously because that's going to be a big part of this conversation, asthma. But I love being in the intensive care unit. I love the acuity. I love being able to fix someone sight on scene. You know what I mean? Yeah. Be able to it's very rewarding because literally you pull them off of death's doorstep, literally right there.
Yeah. And see it happen in real time.
Yeah. And I look back to us in college. I'm like, man, I can't believe I'm allowed to do this sometimes.
Man, I could say that about a few people that we know, but I think we digress a little bit. So maybe translate or kind of segueing into next part of that conversation. So, I love the critical care aspect of your practice. Talk to me a little bit about what you're seeing. And one of the main subjects we're going to talk about is asthma, but in your I guess regular or day-to-day practice, walk me through a little bit of that. We talked about a couple of different things step-by-step, or am I getting that correct? The type of management for the
So stepwise,
it's stepwise. That's it. Yep. Excuse me.
That's okay. I mean, so when we start talking about asthma, I'll obviously get into the treatments and where you start to where you can finish. Do you know what I mean? As far as controlling their symptoms.
So where do you want to start? How about you start, and then we'll just go through it.
So basically, I kind of did I want to do a background. Asthma is a big topic. We could be here for 5 days talking about asthma, let
Yeah.
alone 45 minutes to an hour. So, the biggest things is getting the diagnosis, okay, coming up with a management, a treatment plan. And then I kind of wanted to give updates in clinical practice that changed from when we were growing up. Everyone's puffing away on their albuterol all the time, every day, 6 times a day, and that's considered controlled. Definitely not. So basically, what I wanted to get into first, the main clinical features of asthma, what these patients are going to come into the office with, what they're complaining of, and how to go from there. Okay, the biggest one, like let's say you were coming in because you had asthma as a kid. What was your number one complaint when you were a kid when you came to the office? You got to go to a pulmonologist.
Tightness. So I ended up just going to a pediatrician, I think, because that was what was available, and it wasn't as serious, but it was tightness in my chest. Anytime it was cold, I would go to football practice or track practice, what I'm running. Any exercise-induced asthma is what I was diagnosed with, but it was bronchial. So very tight in the chest, couldn't breathe, wheezing, not to a point where I was having an attack. Like I was needed to go to the ER, but it was wildly uncomfortable.
So exercise-induced bronchoconstriction is actually what we call it now, EIB.
Okay. Yep.
So it's not even it's exactly what you said. So you said bronchial, exercise-induced bronchoconstriction. That's it. So the treatment for that would just be the albuterol puffer, which wasn't wrong back then. Now it's a little bit different. We'll get into that. But yes, so you said chest tightness, shortness of breath, cough, and wheezing. Those 4. Chest tightness, shortness of breath, cough, wheezing. And then how to proceed. You can do a myriad of testing. Some of it is a little bit old school. So the stuff that we stick to now is mainly just pulmonary function testing. You go into a big box in the hospital, a respiratory therapist is there with you, tell you to suck in and then breathe out for 7 seconds until you feel like you're going to pass out pretty much. Okay? That's the first part. Then they do that again after they give you an albuterol treatment or an immediate acting bronchodilator. Okay? And if you have response to that based on a few parameters, there's something called FEV1, which is the forced expiratory volume in a second, the first second after you breathe out. And if you have a 12% response to the albuterol, okay, in FEV1, and your FEV1 increases by 200 mLs, that means 200 mLs better than what it was to start with before the treatment, that's essentially a diagnosis of reactive airway disease because you have the responsiveness to the albuterol.
Okay.
Okay, does that make sense? Do you have any questions about that?
So what if it is not that way? What if there is no reaction? If there's not any kind of a positive, you mentioned what, 18% or something to that effect improvement?
20% and 200.
12 and
200. I apologize.
12, so if I hit 9 and if I hit 150, what's the next step on that? Am I in trouble?
No. Great question. So clinically, you can still justify prescribing a controller bronchodilator or a rescue bronchodilator if patients say they get better, period. So just because you don't have the responsiveness on the test, you can't necessarily say, oh, they don't have asthma if they get better when they use the puffers, period, right? Now, if they don't get better when they use the puffers and they don't have that response, then you have to start thinking about other diagnoses that maybe are not asthma or airway related. Could it be COPD? Could it be heart disease? Could it be obesity? Could it be a myriad of other things, which I was going to get into also. So now you got to think also, asthma is an extremely prevalent condition worldwide. I would say around 300 million people are affected with this disease. It's incurable. I want you guys to know that also. Like that needs to be a very you cannot cure asthma, period. You can treat it, but you cannot cure it. It will never go away. So let's say it's like, go ahead.
No, is that certain types of asthma that is that way? Are there other types that you grow out of, et cetera? Because for me personally, if I sprint, if I try to run a mile as fast as I can in 30-degree weather, I'm still going to feel it, but I don't have that effect anymore from cold weather if I'm running outside as a 40-year-old man as I did when I was 15. So I either didn't have that specifically or something changed where I grew out of it, or I'm no longer as affected.
I like what you said. So if diagnosed with asthma, usually as a child is more allergic related. Older age is more related to other things. So when you have allergies as a kid, that's usually when you have the earlier diagnosis of asthma. Now it can go away, but it also can come back. You can have a straw that broke the camel's back, such as COVID. COVID is bringing asthma back for a lot of patients that had it when they were young. A lot. So that extremely prevalent, post-COVID condition. So, I mean, just from what my standpoint, recognizing asthma, and there's a lot of other post-COVID conditions. I'm not going to go into those because they're not necessarily related to this talk, but they are out there. And then you got to think about how much it costs. So these people that have exacerbations, they go to the ER all the time. And every ER visit costs money. And every admission costs money. This is probably, I would say, one of the top 10 most costliest diseases in the United States.
Is that just because of repeat
exacerbations uncontrolled?
Yeah.
A lot of these patients don't have pulmonologists. They have primary care doctors. And, primary care doctors manage everything. And asthma is a very, very, very specific condition that should have a specialist following it and not just the primary. It's not fair to them because there's so many different types of asthma that are out there now, and the updates are constant. And how is a primary care doctor going to keep up with all that? Because they have to keep up with the blood pressure. They have to keep up with the cholesterol, the diabetes, the chronic pain. You know what I mean? Every other condition that somebody has. If someone comes in to me and says, hey, I have asthma, but I also have a headache, I'm like, whoa. I don't need to know about this. I'm
here for here.
Exactly.
You go here, over there.
But primary care doctors can't say that.
Right.
They have to listen to every single complaint a patient has. So it's not fair that, we expect these primary care doctors to treat asthma adequately because they don't have the time, and honestly, they don't have the knowledge. They just don't. It's impossible. So it's important.
As you mentioned, right? If you come in for a headache, right, and your primary care physician, you don't have the training. You trained in family medicine or internal medicine. You went into practice for whatever it is that you treat. Peds, early adult, and then you are not a board certified pulmonologist or critical care physician, et cetera. So the additional fellowship, the training, the knowledge, you pass it on, you refer in, but that doesn't happen all the time. So I have to assume that you and others like you are seeing a huge influx in patients from post-COVID, as you mentioned, but also these, family physicians that probably can't handle the patient load, one, but two, don't have the ability to treat.
It's not even their fault. They just don't know. They have 10 minutes per patient. They have 55 patients a day. It's not fair. You can't expect these people. So thank God they didn't have a pulmonologist in this area for like 3 years.
Really?
So they had no idea. So they've been trying to manage these patients by themselves for 3 years. So they're still coming to be aware. I've been here for almost 2.5 years and they're still like, oh my gosh, it's a pulmonologist. Thank God.
I can breathe again.
Yeah, exactly. No pun intended. Yes, exactly. Exactly.
So, so like kind of moving forward, we had quite a bit to cover and, just that was a good synopsis. So lead me off here. So we talked about what my symptoms were, right? And then some of the additionals, but then, moving forward from that.
So you got to think also with asthma, there's no pathognomonic clinical symptoms. There's nothing that says if he has this, he definitely has asthma. That does not exist. There's a myriad of testing that you do. If you have one test that's positive for asthma, or it's maybe a little bit borderline positive, then you got to proceed further with other testing, right? So first of all, what do you look at first? Like we talked about, the symptoms. Number one, we said wheezing, right? Wheezing is a huge thing. Now, what about wheezing? There is, I would say, a breakdown of 6 different factors regarding just wheezing that allows you to delve into the diagnosis of reactive airway disease, i.e. asthma. Number one, what type of wheezing is it? Is it when you breathe in or when you breathe out? When you breathe out, expiratory wheezing. That's number one. Okay, wheezing with expiration. Number two, it's episodic. Like you said, colder weather, after exercise. It could be, you're mowing your lawn, whatever, you know what I mean? So episodic wheezing is key for the diagnosis of asthma. Not pathognomonic, but it helps. Okay, another one. So usually it's at nighttime or first thing in the morning. That's when the wheezing mostly occurs. Do I have a really great explanation for that? No, nobody does, but that's just part of the clinical features of asthma. The other thing, obviously the biggest one. So when we talk about treatment of asthma, the first thing that we say, what do you think it is? Can you guess? The first thing when you talk about treatment, like the first, management. The first key of management.
Smoking, if you do.
Trigger avoidance.
Yeah, there you go. Yeah.
You know what I mean? Any type of trigger. It can be like, so down pillows are huge triggers of asthma. Pets that you don't, cats, dogs, dust mites, et cetera. Triggers are huge proponents. And if a patient comes in and says, hey, every time, my wife wears this perfume, I say, number one, get a divorce. And number two,
can't you just go shopping? Can we avoid all the paperwork? Can we just go shopping?
Exactly. So, yeah. So that's a big one. And after exercise is huge, like you said.
Yeah. Mm-hmm.
Okay. And the other thing is most, but not all, improve with treatment. Mm-hmm. Most. Unless, so there's one type of asthma, long-term asthma, untreated, can lead, this is a huge thing. There's a lot of pathophysiology involved in it, and it's extremely interesting, but it's way beyond this podcast, I'm not going to lie. Mm-hmm. It's called airway remodeling.
Okay.
Basically, after prolonged inflammation, there's a massive release of certain types of molecules, in your airway that basically form like a hardening, like a plastering of your airway. It's called remodeling, like I said. And you don't respond to bronchodilators at all because you've been so far gone for so long. Like I have a patient who's never smoked in her entire life, but was not managed properly for, 30, 35 years. And her lung function's down to 32% with no response to puffers because she wasn't treated. So she had remodeling of her airways and now they're stiff. So that's a huge thing when it comes to management, but there's not really much to do regarding that once it gets to that point. So our goal as pulmonologists and primary care doctors is to get them to us soon. And then we want to initiate, big gun treatment if we have to right off the bat to prevent that from happening.
Let me ask you this. You mentioned a couple different things. I've got like an if then. So what if I am obese and I'm needing to avoid triggers in order to avoid an episode of this, whatever type of asthma I have. However, I'm obese and I need to exercise and it's exercise induced. How would you recommend that I go about that if I need to run, but when I run, I wheeze?
Yeah. So great question. So the number one, one of the very, very, very pertinent comorbidities with asthma is obesity. They're like this because adipose tissue increases inflammatory markers in your body that causes asthma. And the only way to treat the asthma is essentially to lose weight. But now I'm not pushing any kind of medications or anything. There's a lot, like most obese patients are also type 2 diabetic, and there's a million of these like type 2 diabetes drugs, whatever. Yeah. But yeah, so that's helping us from that standpoint. Otherwise, it's diet, man. It's not even exercise. Most of these people, they drink pop all the time, soda. Now I say pop because
I know you moved to Ohio. Yeah, you say pop.
Mm-hmm. So number one, that's like
guy grows up in Fort Lauderdale for 30 years, and now he says pop after 2.
Yeah, it's like just stop going. If you cut out fast food, you probably lose 50 pounds in a month. But these people,
it just depends on how much you eat. I'm certain, but
go out here on this road right here behind me. You could probably see it. But there is McDonald's, KFC, Taco Bell, Arby's, et cetera, et cetera, et cetera, et cetera. And if you try to go to a Panera and get a salad, it's like $25.
I know.
You go to McDonald's and they have like a $5 menu where you get a burger, a fry, and a Coke for $5.
You should go out there with a sign. Just be like, hey, by the way, I work across the street, and this isn't working for you.
Yeah, it's not going to go well. And the thing is, I have my patients like, I just had McDonald's before I got here. I'm just like, your BMI is 57.
Yeah.
Why are you going to McDonald's? Like, what are you talking about? And they have their kids, and every one of I would say 5 out of 10 of my patients comes in with some kind of soft drink. Some kind of pop, not the diet ones, Mountain Dew, Pepsi, Cherry Coke. It's a very prevalent in, the Northeast where I'm at, that people drink pop. It is what it is. My in-laws pound that down. It just is what it is. That's what they do.
Yeah. I mean, that's pretty much everywhere. I mean, and even in South Florida, right? It's a beach scene, and it's always bikini season, but that doesn't matter anymore. I'd say over the last maybe 10 to 15 years.
Bod.
Yeah, I mean, I'm not buying New Balances anytime soon here, but, just saying, I'll tell some jokes. But with that said,
not happening. Not happening. Heck
no. But so on that, kind of before I interjected with the if then, but go into some of the treatment regimens for some of the different types and how you recognize when to start, when to stop, things like that.
I would love to. Okay, so. I was going to go the differential diagnoses, but we kind of did that already, heart failure, et cetera, et cetera. And then what you literally just said, conditions making asthma worse before I go into treatment, acid reflux is huge acid reflux because it irritates your airway. So you control acid reflux. Now we're going to treatment, right? Control the acid reflux. Now I'm just talking about secondary causes that you can control that can help you control asthma before you just have a primary diagnosis.
Okay.
Are you with me?
Yeah.
Okay. So obesity, chronic rhinosinusitis, like allergic rhinitis, allergies. Chronic sinusitis is a big one. And then anxiety, obviously, is also like a lot of patients become dependent on their albuterols. They feel like if they don't use it, they're not going to be able to breathe. So it's super. And when you get anxious and you already have asthma, and you start freaking out and your airways become very hyperactive, you're going to have an exacerbation. But it's triggered by up here, right? Okay.
So I case in point, when I used to run track, I would use my inhaler beforehand in almost like preventative care, but I wasn't a doctor, of course. So you would open up my airways. I don't know if that was even legal according to the NCA, not NCA, like FHSAA, but even so, if it's regulated 20 years after the fact, please don't worry about it. But all that to say, it was up here. I was like, well, I'm going to not be able to breathe as well at the end of this 400 race. So because it is cold outside, it's middle of winter, et cetera. So
yep.
Yeah, sorry. Go ahead.
No, I that makes a lot of sense. But now going back to that use of that albuterol. So there are many different types of inhalers out there. Like there's so many. I'm not even going to get into that because I'm not a pharmacist. You know what I mean? I'm not pushing any type of pharma. So the number one treatment that everyone used for asthma back in the day, even now, a lot of these doctors, is albuterol, right? Just albuterol as needed. Here's the deal. The more you use this albuterol, what we've seen is actually increased asthma-related complications.
Really?
With albuterol. They actually have worsening airway hyperresponsiveness the more they use albuterol because they almost develop like, okay, have you ever
resistance
used,
or?
No, kind of, but have you ever used it's like a rebound bronchoconstriction from using it. So have you ever used like Afrin for?
Yeah.
So the more you use Afrin, guess what? The more you have to use Afrin.
Yep.
So it's called rhinitis medicamentosa, basically because it's a vasomotor controller. Like, so every time you use Afrin, it's going to narrow the, your vessels in your nose, essentially, that cause you to run, right? And the more you use it, every time you stop, the bigger they get. So you have this rebound rhinorrhea, rebound runny nose, and that's what we're starting to see with the albuterol. The more they use the albuterol, the worsening their airway hyperresponsiveness gets.
So if I'm a patient and I'm using an albuterol inhaler all of the time, and it's been prescribed to me for however long or whatever, I'm seeing exactly what you just mentioned, and I have to use it more now because it's every so often that it's way more, and it's all day, every day. What's a recommendation? What's what Dr. D'Angelo, tell me how to fix this because I'm sick.
Great, I would love to. So, and you do develop this loss of protection from the albuterol after a while of using it, okay? So now what they're recommending, usually it's if you have mild symptom-driven asthma, the first thing you start is an inhaled corticosteroid, such as a Pulmicort or whatever, just a steroid. That's it. Low dose steroid, period. If you have moderate to severe symptoms, which means you're needing the albuterol almost every day, multiple times a day, period, then you use a combined medication. Then you use a long-acting albuterol-like substance, long-acting beta agonist, plus the inhaled corticosteroid, like a Symbicort. That's what I've been doing. So my rescue inhalers for most of my asthmatic patients is Symbicort, period. And that's the combined, it's formoterol and budesonide. So the long-acting beta agonist, which is the formoterol, and the budesonide, which is the inhaled corticosteroid. That is my new rescue inhaler because the beta agonist portion, which is something that decreases airway hyperresponsiveness, spasm, does not decrease inflammation, which is the big driver of persistent untreated asthma. The steroid component is the key for anti-inflammatory airway disease.
So the combination of the two is what would treat not only the symptom, but then the kind of long-term effects or lack thereof of whatever the inhaler would do.
Correct. So if you just use the albuterol, that term that we talked about 5 minutes ago, the airway remodeling, is still occurring because you still have persistent inflammation, which is causing the hardening of the airway, period. The way to decrease that inflammation, again, is to add the inhaled corticosteroid component, period. Okay. So now there are two steps to managing asthma, two different types of treatment. There's a preferred one and there's an alternative one. The preferred one is what we just talked about. So stepwise treatment, remember? So this is the key for asthma. Step one, as needed, inhaled corticosteroid. Okay. Step two, you can go up to as needed inhaled corticosteroid plus the beta agonist long-term component, which decreases the airway hyperresponsiveness and the inflammation. And then step 4 is you just kind of increase the dose, right? You start on a lower dose. There's multiple doses of these steroids. Usually the component that is the beta agonist component for the airway responsiveness stays the same, the dose. The steroid component is what increases in these medications.
Right.
Okay.
I would assume because of the whatever the inflammation is, if it's too much, then the other doesn't work. Is that correct?
Mm-hmm.
Yep.
It's in higher doses. So
right.
now, then, once you get to the highest level, this is when we're going to go into my bread and butter, which is these biologics.
Biologics.
That everyone is talking about right now. They've been out for years.
I have no idea what that even means other than from our conversations. So talk to me like I'm 5. Tell me what a biologic is and why it's important.
Great question. Okay, so biologics are basically, they act at the beginning of the inflammatory pathway versus the end. What happens when you get a really bad asthma exacerbation? What does your doctor usually prescribe to you? Steroids, prednisone, IV steroids. Prednisone is, the side effects of prednisone are innumerable.
Yeah.
We're talking about, cataracts, osteoporosis, frequent infections, cavities, diabetes, weight gain, fluid retention, hypertension, stress.
The Robin Williams, anal leakage. Like that sounds like an effect to me, not a side effect.
Yeah, exactly. Talking about like Patch Adams or whatever?
No, what he did is stand up on HBO.
I don't remember that.
So the Ethidol, or I kept, not saying it for the children viewers here, but you got to watch it if you haven't. But that's what it is anyways, the litany list of side effects of this. Exactly.
So now, what they have come out with a few years ago, I'm not going to go through all the biomarkers they inhibit, the interleukins. It's unnecessary because I'm not going to talk to patients about that, right? And now I'm talking to patients. If this is a lecture topic for a medical school, I would have all that included, but it is not. So what these new medications do is they stop the inflammatory pathway before it starts.
Okay.
That's the key. But to get there, you have to be maxed out on all of these types of therapies. You have to be on step 5 of, this treatment plan. Okay.
So you're talking about biologics. So the question is this, and again, I know nothing about this other than what you just told me in a previously bits and pieces, but is it recommended? Is it possible to get to the biologics step without those first 5? Because it seems like it would be preventative as well as treatment based for symptoms that present. Am I correctly assuming that?
So to be qualified for these biologics, which usually they run about $4,000 a month, give or take.
Jeez.
Yeah. So insurance has to be able to cover these things, and you have to meet very certain specific criteria. So you have to be maxed out on a high dose inhaled corticosteroid combined inhaler, have to be maxed out on it. Most of these other medications at least require 2 bursts of prednisone over the past year to show that you are uncontrolled, and you have to be compliant with all of these things. And if you really just want to knock it out of the park and get these patients prescribed for it, you have to check their eosinophil count. Now, what the heck is that? So when your primary doctor does blood work for you, you get the printout, and usually, hey, this looks normal. Not necessarily. So the eosinophil is a type of white blood cell that mediates inflammation. It also treats parasitic infections. Okay, that's what it's for. This is a developed country. We're not too worried about, going on the streets and there's dog dung. You know what I mean? People aren't crapping on the side of the road. You know what I mean?
Right.
Not most times.
Not most times.
No, unless you go to Philadelphia. No, I'm just kidding.
Downtown New York City every now and again. It's all right. Not a big deal.
Exactly. So
I lived there for 6 years. I can say that it was halfway my home. So
I know you did. I know. I remember. You and Mark
talk shit about your exes,
trying to be models or whatever the heck you guys are doing.
Yeah, I was the model hanger on.
They
don't have a lot of bald models, pal.
No, they do. What's his name? I don't know. Actually, I have no idea.
Tyrese.
Yeah, there you go. But he's African American, so that doesn't count.
Correct. Yeah.
So,
anyways, you were saying.
Yes. So we digress. So basically, the eosinophil. Okay, like I said, from our topic today, what we're going to focus on is the fact that it mediates inflammation and allergies. It's very prevalent in patients who have a lot of allergies to pretty much everything in the environment. Period.
Right.
Okay. So sorry, I didn't mean to do that.
Good.
The eosinophil. The normal level of an eosinophil is usually less than 150. But on a blood count, on a CBC, whenever you get, your blood work done by your primary doctor, they usually do a CBC with something called the differential, which breaks down the white blood cell. So there's a few types of white blood cells. We don't need to get into that, but the eosinophil is one of those subtypes. Okay. It mediates inflammation. So whenever they see it, remember the little red arrows that go up and down? Like, hey, look, this is abnormal. We need to focus on this. The level of eosinophils up to it being abnormal is 800. 800 to 1.5 to 8 is the parameter that they say is normal on a CBC.
That's a big spectrum.
Anything more than 300 will get you qualified for one of these medications. More than 300, and it doesn't flag until it's more than 8.
Jeez.
So you have a 500 microgram gap of patients that fall into this inflammatory asthma that no one knows because they don't specifically check for this type of white blood cell because they don't know about it. You know what I mean? They just don't know. Like it's not as prevalent to them because they are looking at so many other things, right? They're looking at anemia. They're looking at, if this patient has leukemia, if they're looking at the cholesterol, they're looking at the glucose. They don't specifically look for this type of blood cell because it's esoteric to their practice.
Right. And I got to assume also it's what age, weight, height, a lot of different kind of idiosyncrasies into reading that. Is that correct? Because if you're 650 and you're 60 or you're 650 and you're 25, is that a difference maker or no?
No. So it doesn't really matter. Age is nothing but a number for these. For this specific marker. Usually, though, it's higher when you're younger because that's allergy. Like asthma is more allergen mediated when you're younger. Right. So it's higher. Okay. Right. So, but if it's so high, then you have to look for other conditions such as parasitic infections and stuff like that. You can't rule them out if it's like in the thousands.
Right. Something like cancer or AIDS, right? If your T cell, white blood cell, all the other things are super, super, super high or super, super, super low, it's something else.
Yes, exactly. Yeah. So there are something called hypereosinophilic syndromes that's another podcast altogether. I'm not gonna lie.
Okay. Hey, episode 2 with Dr. D'Angelo, hypoeosinophilic.
It really is. Syndrome. Yeah, there's a lot of them. So, but these medications can be used for those conditions also. So, like there's about 5 different ones out right now that you can prescribe for these patients. And most of the people that are prescribing them are allergists, immunologists, ear, nose, and throat doctors, and pulmonologists. Those are the big 4 that are prescribing these medications because they're the ones that these patients get forwarded to, and we know what to look for, right? This is our bag, right? We can't. This is our specialty.
Stupid question potentially, but are there biologics for different specialties? Like, would there be one for your brain? Would there be one for
are there biologics?
GI or things like that?
Yes, but they get 100%. There are it's an immunomodulator. Just call it something like that. Something that prevents your immune system from doing something that it shouldn't be doing normally, right?
Got it.
Yeah, for like multiple sclerosis, sarcoidosis. Of course, there's many biologics out there for these types of other conditions.
Sure. I mean, typically people just call that medication, but since I'm talking to a physician who actually knows what they're talking about, that's why I was asking, because somebody like me, the first time I'd ever heard the word biologics was from you. And that was a month and a half ago.
Well, yeah, we call it, but it's an immunomodulator.
Right. Okay.
It shuts down a portion of your immune system, just like other kind of medications do. But these ones do not really inhibit the immune system overall like the other ones do. Like they don't predispose you to like bacterial infection, to viral infection. They don't inhibit that main immune system that fights off every other type of infection, like pneumonia and stuff like that. Like these other like think about chemo, right? It's an immunomodulator. It shuts down everything, but then it predisposes you to everything. This does not do that.
Specifically targeted towards the eosinophils or eosinophilia, correct?
Exactly. Yep. Mostly, yes. But
which makes it unique and amazing for asthmatics.
Correct. So I have had patients that come into me with uncontrolled symptoms for years. I'm talking decades long, right? And non-smokers, and just like, well, I can't, I have persistent congestion, chronic rhinosinusitis, I have the post-nasal drip that exacerbates my asthma, I'm always coughing, and I figure out the best medication to get these people on. That's when it comes a little bit tricky because they are not, if you talk to the reps, they will say they are, one's better than the other one, and better than the other one, and better than the other one. But as a physician, from my standpoint, they work pretty similar. They really do. I've seen, because I've prescribed so many, that certain, I'm not going to get into this either because I don't want to propose one medication over another. I've seen certain subtypes of patients. Let's say I have a patient that has something called chronic bronchitis, which is under the umbrella of reactive airway disease, COPD, et cetera. I prescribe them this type of biologic, they get better. If I have a patient that just has, let's say, a persistent dry cough and airway hyperresponsiveness, I'll prescribe them this one and they get better. Now, is there any science behind this? Not necessarily. It's kind of just based on, as a provider, who I see improving better with certain symptoms on which biologic.
Well, sure. You're like a coach at that point, right? You're calling different plays for different teams' defenses. So you know what you're looking at. You've done the research, you've done the studying, you've seen them before. So this is what we're running against this defense because I know what's coming.
Correct. So now, getting into that, now because these medications to most people are new, they're not really that new. I can remember during fellowship having, these going to dinners and having these people that from different types of pharmaceutical companies talk about these medications because they've been out for a while.
Yep.
But to most people, they're new, and they're shots, they're injections. So that also gets people a little bit weary, right? People would rather a puffer. Well, why would I all of a sudden need an injection for asthma?
Do they do it themselves? Is it self-injected? Like an insulin needle or what have you? Yep.
Not even. It's like an EpiPen.
Oh, okay.
Put it on the skin, tap it, wait for it to go.
Yep.
Hear another click, take it off.
All right. Easy peasy.
Yes. So now the number one side effect that people are concerned about is something called anaphylaxis.
Yeah.
The anaphylaxis is that with that initial shot, you can have that hyper allergic response, which is actually counterintuitive if you think about it. But it happens to some patients. I've never seen it, but it definitely is the number one side effect. The other ones, the big ones, are injection site pain, a little bit of redness. So usually if I start them in the office, which I recommend that they go to the prescriber's office for their first injection, I watch them for 10 or 15 minutes, and if they're fine, they go home.
Yep.
So, and the majority of my patients have had significant improvement of their symptoms with these biologics. Now, the caveat is you cannot stop your asthma treatment like the puffers just because you're on the biologic. That is the controller.
Got it.
That does not go away because asthma is not curable. Just because you're inhibiting the inflammatory pathway doesn't mean you're not going to have airway hyperresponsiveness still. Right?
But you can pull off of the inhaler, I have to assume, from regular daily, hourly usage. No?
Okay,
no?
You can pull away from your rescue.
Okay.
But you can't pull away from your controller.
Okay.
That are at least the recommendations that they're dealing with now. They haven't changed those yet. But they want all the companies, at least the insurance companies that are prescribing these medications and covering them, want their patients to remain on their controller bronchodilator and not this be their end-all, be-all treatment. Because this is the final step. This is the peak of that step ladder.
Yep.
So just because you're on this, you can't all of a sudden be like, we negate everything that we've been doing for years.
Sure,
you know
but what it does, I think, what it sounds like it does, anyways, is that once you get onto these biologics, it makes you go from step 5 back to step 1.5.
Correct. I would say 1.5 or 2. Correct.
Yeah.
Correct. But you need to be on a controller. You can't just be on a rescue.
Right.
You have to be on a controller. You can get rid of your rescue. That's what I want to see happen. That's my goal. That's how I know you're controlled. You're not using your rescue inhaler anymore. That's controlled to me.
And I'm certain it's patient to patient, case to case, but timeline, like how long does this take to kick in? Is it, weeks? Is it months? Is it a year?
Very good question. So each of these medications is dosed differently. One of them is every 2 weeks. One of them is once a month for the first 3 months and then every other month. And then the other ones are once a month. Okay. So it depends on the patient, again, which I think, benefit from the more often or the less often. Most of the time, the one that's less often, they know when they need their next dose.
Yeah.
Like it's coming, which is a good thing because it's working. But like the day or 2 or 3 before they get it, they're like, all right, come on, baby. Like I need this medication. But you can't take it earlier because you're not going to get it earlier. Yep. You know what I mean? It is what it is. So, that's the key then, how kind of I want to prescribe these certain types of medications. The more controlled ones, or the ones that haven't been on, what is that noise? Haven't been on the maxed out for years and years and years. I'll do the one that is a little bit less often, but the ones that have been on years of treatment, multiple doses of steroids over the past
year, have to
I'll do the more often. Yep.
Yeah. You got to hit it harder.
Some patients, don't tolerate them, honestly. They just don't. They don't feel like they benefit. And then if they don't, what do you have to do? You have to look for something else.
Yeah.
why are you not benefiting from this medication? What else is going on? Do you have heart failure? Do you have another condition that we're missing that's preventing you from, because in the science, you should be getting better.
Yep.
Right? Because this is like, I tell patients when I put them on these type of medications, this is it for me. Like, this is, I've done all that I can do. Like, from my chair right here, this is the last ditch effort. And if you don't get better on this, then something else is going on.
Right. And that's good news on both ends, right? Either you're going to get better, or we will find out that it is something else that we will treat that.
Well, so someone will. But
yeah, we as a hospital practice, we as
exactly.
we as medical experts.
Yes. So like sometimes, like honestly, if I have one of these, so my practice is 5 family medicine internists, like internal medicine / family medicine doctors, and then me. Yep. So if I have these patients, I'll like literally bring, and they'll refer to me. I'm like, hey, doc, can you come in here real quick? Like, this is what I've been doing. What do you think? We'll do a shared medical visit right on site. That's the benefit of this practice, because I'm friends with all these guys. I mean, the guy right here that I share a wall with is my next door neighbor. Literally, he lives across the street. So
there's good camaraderie there. There's a good referral base. So
saying,
do you?
Go ahead.
No. I was just saying, do you see a lot of exactly that, right? A lot of get on the biologics. This is the last step. This is what we're treating, and then it's something else. Like, are you seeing more of that, or are you seeing more? I don't know if that's an easy question to answer or not, but
so it's going back to what you asked me before. How long do these things take to work?
Yeah,
every single patient's different. Everyone's like they say, like there's a loading dose. So like for the one that you get once a month for the first 3 months, after that 3rd month, you should start really seeing some improvement, because then it's every other month. You know what I mean? And the one that's every 2 weeks, you should start seeing relatively quick, because it's often. But like I said, everyone's different. So like I had a gentleman that I just started the once every 2 week medication on, and his cough and everything has significantly improved after, I want to say, about like 3 months, along with his shortness of breath. But he still has the persistent congestion here. Maybe because that's been going on for longer, so it's taken longer to treat. You see what I'm saying?
Yeah.
Or is there something else? Does he have another reason why he has such bad sinusitis? Are there polyps? Does he need to have an ear, nose, and throat evaluation? Does he need to go look back on those sinuses? Does he need a washout? You see what I'm saying?
Yeah.
Like in theoretically, he shouldn't have that anymore.
Right. So and as you peel back the layers to that onion, and you're just like, oh, well, I've got this. Oh, wait a minute. There's now this, or there's, you fill in the blank, right? With the sinusitis and, or, whatever that additional thing may be. Probably couldn't see that unless the one was treated, right? Or it wouldn't be focused on, or as you wouldn't be as hyper aware of it.
Correct. Because now, like, why isn't it all of a sudden getting better? Like we've knocked down every other, like, pillar or whatever. We dotted I's, crossed T's, but now there's this outlier that's still not getting better, despite the fact that he's on he's been treated for everything as far as respiratory goes.
Right.
So
then send him another specialist. I've specialized away here.
Exactly. So like I've done all that I can do from my chair, like I say. And then, if I have to refer out to another specialist, then I do what you have to do. But, it gives you the ability to look for something else finally, because now we've treated everything else that we can treat, and now there's this thing that's still persisting. So maybe this is what we've been missing the whole time. Yeah.
And you wouldn't necessarily be able to recognize that as readily, just because there's a plethora of other symptoms that are overwhelming that the patient presents with, like, oh God, we got to treat this. He can't breathe. He's got all of these things, but then those are gone. Oh, by the way, you've still got XYZ. You need to go here.
Correct. So what I want these patients that are listening to us talk today to realize, that there are options out there for you regarding your persistent asthma condition, your persistent wheezing, chest tightness, as frequent as it could be. If you've been on steroids multiple times per year and you still need them, but every time you get them, you get better, and every time you stop them, you get worse. Yep. This is the next step to talk to your doctor about these possible biologic medications that inhibit the inflammatory pathway before it starts. That is the whole point of this conversation. I want you guys to realize that you're not stuck, because patients feel stuck, and it's very frustrating. They don't want to go to doctors anymore because they're not helping them, because every time they go, they put a little patch on it. They give them the prednisone, and they go home and they get worse the second they stop it. And they don't want to be on prednisone. It makes you feel like you're going to jump out of your skin. It's a steroid. That's what these bodybuilders actually do take, a type of steroid that's oral that's very similar to prednisone. You know what I mean? So, these patients have all these side effects from them, but they keep needing them because that's the only way they can breathe. That's the only way they can feel comfortable, or they just have to live with their persistent cough and congestion and just be like, this is just me. It's not. It doesn't have to be, is my point.
And I have to imagine, you mentioned 300 million people worldwide. That's the entire population of the United States, but globally. So with that said, there is someone, it only matters if there's one, but thousands of people that are doing exactly that. I mean, I guess technically was one of them at a much lower level, but you get a steroid, you get an inhaler, and you call it a day. And then you just live with it.
Live with it. That's what they say. There's nothing I can do. Doctors say that. I mean, we do say that, like, unfortunately, hey, you're not going to die from a cough. But it's very, like, it causes issues. It's embarrassing. Like, I have this one poor kid, that kid just, like, I mean, he's always doing that. How are you going to live your life?
Yeah.
You can't
Well,
live
it's
like that.
And with exercise and with, I mean, good night, all of the other things that come along with being short of breath, taking the stairs. I mean, I don't know, fill in the blank with whatever you can or cannot do, or what's uncomfortable for you to do. And, if and when it is this or a few other things that are treated by these biologics, these miracle discoveries.
I'm not going to lie. They really, they kind of are. It's changing the game 100%.
Well, it sounds like, and it's changing lives too, because, being able to lift that weight off of somebody's shoulders. I mean, you got an elephant's foot on your chest half your life.
Yeah, but it takes time. You have to be patient, because you have to be on the high dose inhaler. You have to, have these certain other conditions, and then you look into it. So now this is going to be, that's not changing topic necessarily, but let's say you do look at your lab work and your eosinophils are not high, but you're on maxed out therapy. You know what I mean? And you've been on 2 doses of steroids over the past year. You can still get approved for these medications with normal eosinophil levels. For some.
Got it.
Not for all.
Case by case?
Yes. But let's say you were on a burst of steroids when they did the lab work. Your eosinophils are going to be low because the steroids are going to be dropping those eosinophil levels.
Exactly. So, and people are not necessarily going to get off them to do blood work because you're uncomfortable and you don't.
It's case by case basis. You know, as a physician, how to look beyond those little things, to see if this patient's going to benefit from it. They don't have to be the cookie cutter hypereosinophilic syndrome. You know what I mean? They don't have to be this, that, no.
Exactly. And I got to think on a patient level, we have not because we ask not. My grandma always used to say that, right? So just ask the question, like, hey, can I get this level? Can you look at this level and see where I'm at? Because
no patient would know unless they heard this conversation. No patient would be like, hey, because they don't have that arrow. That red arrow is not there.
Exactly.
Unless it's,
and that's why we're having it.
Yeah.
And even if it's crazy low, ask the question anyways, because if you're in step 1 to step 2, touching 3 of what we just talked about, you may be a candidate, but also you need to have the conversation.
And sometimes you could bypass all those steps and just go right to step 5 because these patients, what they have. That they're, uncontrolled. They've had albuterol. They use it 5 times a day. They have a nebulizer. They use it 4 times a day. You're not going to start with a low dose inhaled corticosteroid. These are patients with severe persistent asthma.
Very advanced. Yeah.
Yeah, exactly. There are different stages of asthma. There's mild, moderate, severe, and then, obviously. So that's how you would treat them. But you would treat them based on how often they use the albuterol, and that's how you kind of discern, like, their severity. But that's, like I said, that's for the doctor to determine. It's not a difficult thing.
But for the patient to ask, right? The conversation starter comes from the patient because the doctor's not necessarily going to look for that as a primary care physician because A, it's not their responsibility, B, it's not in their wheelhouse, and C, the evidence isn't presenting themselves to the blood work necessarily.
Okay, and it could be. Though it could be in their wheelhouse. The thing is, a lot of these insurance companies will not approve a primary care doctor to prescribe a biologic. It won't happen. They don't let them do it. They're like, no, you have to go see a specialist.
Well, that makes sense though. You need the training to be able to diagnose, to be able to treat.
Yeah, correct.
So,
and insurance is just insurance. You know how it is. It can be very difficult. A lot of hurdles.
Separate episode.
Yeah, I know, right? That was the take home point that I wanted to drive in. Like, you're not alone. You're not stuck. There are options for you. Now that you know the right questions to ask, you know what I mean? Focus on that eosinophil count, focus on your persistent symptoms, how many times you've needed steroids over the past year, how many times you've needed antibiotics for frequent exacerbations, even though antibiotics are not the treatment for this at all. You don't necessarily have an infection. You just have persistent inflammation that's exacerbated by what? Environment, any type of trigger. It's not necessarily an infection. Doctors get prescribed antibiotics for these patients nonstop.
Oh, yeah. I can't tell you how many Z-Packs I've taken for no reason and that haven't worked and done anything. But then I'm still
resistant.
Yeah, and that's what I am. Like my mom, when she was a kid, she took so much Benadryl that she had no more histamine left in her body. So just stopped producing
You say Z-Pack. That's actually funny. So they actually started making a recommendation to start azithromycin for patients that have severe persistent uncontrolled asthma.
What?
And you give it a little bit randomly. Yeah, this is brand new. I have to even do my further research on this. It literally was just a recommendation that was made very, very recently. So I don't want to go into it right now because I haven't done enough research on it. But you triggered me to think about it. But yes, they have started azithromycin like sporadically on these patients, and they are seeing improvement.
Well, I can't wait to hear the research that you do on that, because even as a layman, I'm curious as to why.
I mean, because it's anti-inflammatory.
Well, yes,
it's not just a treat. It doesn't just treat infection. It treats inflammation also. So I think maybe a lower dose that's spaced out is not going to cause a resistance. It just causes anti-inflammation. That's what I think. But like I said, I have to do way more research into it. I don't even want to broach that topic just yet.
I'm on meloxicam right now because I had tendonitis in my elbow. So like there are other low dose steroid, non-steroid anti-inflammatories. Don't roll your eyes at me. I can see it.
I'm like, oh.
I'm not the doctor here. I understand that.
We're not talking about chronic NSAIDs and asthma. You don't want to get into that. Trust me. We're not doing that.
No. I wanted to talk about me for a second. My elbow's killing me.
Yeah, there you go. Good.
But I'll go to the elbow doctor for that. But
there you go.
So kind of wrapping up here on this particular topic, like what else, if and when, do you want to touch on anything else? Or, I mean, we covered quite a bit, and I think quite a bit that will touch thousands of people if and when they want to tune in. So. And it's important because I am one of them that, 25, 30 years ago, I would have loved this information. My parents would have anyways. I would have loved for them to exist. So the fact that they do and the information does, and then you can now go talk to your physician or Dr. D'Angelo if you're in the Alliance, Ohio area. Or
Canton or Akron or Salem, whatever. There's a very big, diameter of patients that are not being treated. But there's no pulmonologist. It's not their fault. There's no specialists in these areas. There's a few, but not many. So they can always like you said, the take home thing is, that your persistent symptoms can be treated. You have to be maxed out on certain types of inhalers, especially ones with a steroid in them. You should not be using albuterol over and over and over again, which will actually make you worse than better. You should be using something combined with a steroid in it. And then if you are on all those things, then the next step is to ask your physician about a possible immunomodulator, such as a biologic for asthma.
Right. So where and when are we doing the next episode, buddy? I'm excited to continue on.
I would love to, actually. I mean, I have so much to branch off of. So I would love to go into like the azithromycin thing, for airway disease. We could start I would say I would love to start the next podcast with that and just kind of go back to this topic, but then talk about another topic. Yeah.
And we talked about COPD a little bit too. I mean, there's like 10, 15 different things that we can just rip through. But I mean, this has been unbelievably informative.
Yeah, good. I'm glad. Like there's lung nodules for primary care doctors that know when to refer, when not to refer, which is a huge thing as far as lung cancer screening goes. Huge. So, I mean, that topic is massive and it's like out there everywhere. CT guided like lung cancer screening. So I would love to talk about lung nodule follow-up for the primary care doctor and for patients in general on the next topic. I think that'd be great.
We're going to do that. We'll talk about that off screen, off air. But I appreciate the time and good hanging out with you as per the usual. But Dr. Chris D'Angelo, board certified internal medicine, critical care medicine, and pulmonary disease physician based in Alliance, Ohio, but the Quad City area of Akron, and then continue on in the 100-mile radius. I'm not certain of my U.S. geography at this point.
That's pretty far, but yeah, but it's close enough. But yes, it was great talking to you. It was great.
Nah, man, it's been a pleasure. Thanks for coming on.
Thanks for having me. I'll talk to you soon.